Well, we've been talking to a lot of patients across the country about their healthcare stories. Today, I'm excited to have a chance to talk to Dr. Shawn Whatley, who is a family doctor north of Toronto, and he's a past president of the Ontario Medical Association, and he's also the author of the book, No More Lethal Weights. So I'm excited to get your perspective, doctor, from the front lines of what you've seen on a daily basis and what you're aware of, because you're not just, I would say, a typical family doctor. You've thought obviously a lot about the system, how we reform it, how we fix it. So thank you so much for joining me today.
Oh, thank you, Colin. My pleasure.
I want to start off very, very big picture. And if we can generalize about the Canadian healthcare system, is it possible to talk about or say some things that we're doing right now and some things that you think we really need to look at fixing? Can we generalize across the country that way?
Yeah, absolutely. We could even chunk it down to, costs versus access versus quality. But I think most people will admit, even if they're violently against our current system, and most people actually think our system, yeah, there are problems, but overall we're not doing too badly in some areas. We do really well if you happen to be unfortunate enough to get hit by a car and you're bleeding on the side of the road. I mean, our system works well, especially if you live within an hour of a trauma center. A helicopter is going to come, scoop you up, send you to a top-notch team. And certainly on our international comparisons, we do very, very well on trauma care. We do very well on certain kinds of cancer care when you finally get that care. I think we do quite well on immunizations. I was just speaking with one of the experts who runs the whole immunization approach at the provincial level, but he also worked federally. And I think if you have something that's fairly predictable like that, we know how many kids are being born, we know how many of them are going to hopefully get their immunizations. The government does quite a good job. I don't know if it does an efficient job, but certainly on the service end of things, we're doing quite well. So there are reasons to be positive and to be hopeful. The challenge comes, though, on everything else that's maybe a little messy, it's not concrete. People just feel unwell. I had a patient come to Emerge years ago and said, I feel old.
Mhm.
Well, how do you deal with that? What's the length of time between saying I feel old and actually getting a diagnosis? It turned out that the poor fellow was riddled with cancer, but all he could tell us was I feel old. And it was humbling for a lot of us actually to realize, oh, we shouldn't have. When you hear something like that, you go, oh, come on, why are you here? Why did you come to Emerge? Don't you know any better? And it turned out, no, that was exactly the place for him to be. So when you get onto that side of things, where you're dealing with not so concrete presentations, vague descriptions of illnesses, our system maybe doesn't, there's huge opportunity to improve, to put it politely.
And from what I've seen with the research, we do struggle when it comes to waiting lists for many procedures, seeing a specialist, getting a surgery for something, your hip, your knee, your back, that type of thing. It doesn't look like we're doing as well as other countries. Is that something that you've noticed as a family physician? And are there any stories that stand out in your mind? People having to wait a long time, is that a concern for you at the front lines of the healthcare system?
Absolutely. And it's always the tragic ones that stand out for you. The challenge is we're talking at the anecdotal level, right? Well, I know this guy who waited 4.5 years to see a neurologist, and that one actually made it into the newspaper. Or the tragic case of Laura Hillier, who was a teenager, needed a bone marrow transplant. There was a match found. The technology was all in place, but they just couldn't get her a hospital bed. And so after waiting for 7 months, she dies. Or Brian Sinclair, 38 hours in an emergency department waiting room in the Winnipeg area. That's in your neck of the woods, I think.
Yeah.
And he was found, he had already passed away in the waiting room itself. The challenge, and certainly when I do radio programs on this topic, is you'll get people calling in and saying, you know what, I am so sick and tired of people complaining about our system. I got my hip replacement. I got my procedure. I didn't have to wait too long.
Mhm.
And they're right. They're right. But it's a bit the way I frame that now is it's a bit like the survivors of the Titanic. You know, the few lucky ones who got in the lifeboats and are snuggled up under their blankets, and they're eating survivor snacks, and their sailors are rowing them to the shore and saying, you know, how dare you criticize the system when all around them people are dying in the freezing water. So
Yeah.
I think the compassionate response for us is to say, how are we doing for the people who fall through the cracks? It's not good enough that our average wait times are not too bad for some things. At least the government now, for the most part, and this is kudos to the Liberal government, at least in Ontario, where they said, okay, yeah, we have to look at 90th percentile wait times, which means how long did 9 out of 10 patients have to wait?
Mhm.
But I would even say we should look at even more than that. It's kind of like saying, what are the average number of parachutes we need for this airplane in case we go down, or what are the average number of life vests we need for a ferry boat? Well, that's not the way you think in
Yeah.
emergency services or healthcare services. You have to think, if this boat can hold 230 passengers, we should have 230 life vests. And so you're looking at the margins, because one death is terrible. And
Mhm.
so in healthcare, I think we need that change of mindset as well, and stop talking about averages, stop looking at the lucky people who got into the lifeboats, and really focus on the huge amount of suffering for the people who didn't get the care they needed. And unfortunately, it's a lot more people than we care to admit.
Yeah, well, you certainly don't want the person who's not making the lifeboat to be your spouse, a mother, a father, even yourself, right? I mean, I think that's a good point, is that there are these cases. I mean, as an organization, we've highlighted, we're big into stories, and so we like to bring to light some of these statistics of people that are having to wait a year or 2 years for different procedures, because it's pretty awful when you go from having a very active lifestyle where you're, one lady we spoke with, she was a senior citizen, and she loved to cuddle her grandkids and go walking regularly and exercise and travel and lead a very healthy lifestyle. And then, boom, once her hip pain began and it was clear that she needed a hip replacement, well, suddenly she was confined to her apartment. And it's just tragic to see, to visit with her and see that she couldn't even put on her socks without using a special little device to get her socks on. She couldn't cuddle with her grandkids. It's very troubling, and you don't want that for yourself or any loved ones. When it comes to, we've talked about um, waiting lists and the fact that they do occur. And I mean, there's essentially a rationing that goes on, is there not, where you have governments that say, well, we're going to provide enough funding for this many procedures this year, and if you don't fit into that chunk of procedures, then you're on the outside looking in, and you're going to have to wait until next year, or whatever the case is. Is that a fair assessment from your perspective?
Yes, well, there's two main aspects of rationing in Canada. One is by wait times, and the other is by geography. So you'll get a very different kind of care. Mind you, Thunder Bay, I grew up in Thunder Bay, yay, Thunder Bay. But you will get a different kind of care in the north, or the northern parts of Ontario, than you will in southern Ontario. So we ration by geography, but we also ration by wait times and wait lists. We're very quick to criticize every other country that rations by whatever approach that they end up using. Um, but ultimately, if the patient is not allowed to make the decision about when they get care, then someone else is making that decision. And when someone else is making that decision, they are rationing. In Europe, they're very comfortable using the word rationing, but for some reason in Canada, uh, you're not allowed to say that. At least if you're a politician, you're not allowed to say, well, we're rationing the number of hips so that we meet a target wait time of 186 days or whatever it is. But yeah, no, it's a reality of a publicly funded system.
It's not a very good set of communication tools if you're in, in politics.
No,
You're
no,
you're trying
not
to
in Canada.
That's for sure. What about rationing in terms of the procedures that are available? And anecdotally, I've heard this, where people will say, well, in Canada, uh, this is the only way of addressing that particular health problem. This approach is one that doesn't cost a lot, and maybe it's more invasive for patients and whatever, but it's cheaper, so government does that rather than this approach, which costs more and is more convenient for patients. Is that something that you've ever seen in your
Oh
experience?
yeah, all the time. And actually, in the pre-show, I should have suggested this as an even simpler example, but I'll throw both examples at you. So when I worked in Emerge for years, the first question I would ask people when we're getting ready to send them home or to put a cast on or whatever, do you have health insurance? Do you have a medical plan? You do? Okay, we'll give you the drug that I think would work best for you, most convenient. You take it once a day, that sort of thing. No drug plan. Okay, do you feel like paying for this or not? Can you afford to pay for these medications? But when it comes to a broken ankle, for example, we could put plaster, old-fashioned plaster of Paris.
Mhm.
It's wonderful. Your bones don't move, but you can't walk on it, or at least unless you put a special walking boot on it, which we charge you for. But if you want the free version, you can't put weight on it. You have to use your crutches for, keep your foot right off the ground. You can't scratch yourself. You can't wash your foot. You can't do anything, right? It's stuck in a hunk of concrete. That's the free version. Or I say, okay, if you have a health plan, well, I can offer you this nice inflatable cast here, an air foam walker, and you can it'll hold your weight up, and you can take it off and wash yourself and change it, put a sock on or not, and you can scratch and it's not smelly and not. You get the idea.
Yeah, yeah,
So the free option is not so great. And if we have time, I can tell you about varicose vein surgery, right? I
yeah,
worked
for
for
sure, sure,
a
yeah.
number of years, yeah, with our local vascular surgeon. That was back when we only had one for a catchment area of 1 million people. Well, varicose veins are not just unsightly for many people, they can actually cause ulcers. So, if you've had a large varicose vein, and maybe for your listeners too, if they've noticed skin changes around their ankles, sort of going brown, talk to your doctor about it. The next step after those skin changes is actually to get an ulceration, and it can take months and months to heal. It really ruins people's lives, all because of a varicose vein.
Mhm.
So the treatment for those large varicose veins that the government offers is what's colloquially known as vein stripping, right? I got my veins stripped. Well, what that means is you go through a whole process, preoperative visits, you see the specialist, you eventually get to the hospital, you get put to sleep, and you have a whole bunch of cuts put all down your leg, just about an inch long or so, but all down the vein. And the surgeon has to tunnel under the skin along that vein, burning off all the tiny little blood vessels that are connected to it or tying off the large ones. And then they have to tunnel up from another cut in the skin farther down your leg and tunnel backwards to meet up to the first tunnel. And over the process of an hour, several hours, depending on how complex the vein is, they'll eventually get it so the vein is completely tied off and they'll pull that vein out. Well, your recovery process is brutal. I mean, you've got all these cuts on your leg, you're all bruised up, someone's tunneled under your skin from top to bottom. But that's the state covered option. The other option that's out there, which the government doesn't pay for, is something called endovascular laser ablation. And what that is you lie on a bed in a clinic, no going to sleep. You get some needles that give you freezing along the length of your vein. And then there's one slightly larger needle, but it's still just a needle. And a catheter is fed into your vein under ultrasound guidance, so you know exactly where it is. And when we get it to the right spot, we hook it up to a laser machine that automatically withdraws this laser down the length of your vein, and it essentially closes the vein as the laser is being withdrawn. The whole procedure takes an hour or so, but it's not covered. So you're spending $1,500 for something that is way less painful. You're back to work within a day or two instead of 2 weeks off work. No general anesthetic, and especially for people who can't tolerate being put to sleep because they have a bad heart or bad lungs, this is really their only option. So every specialty out there has examples like this where, well, here's the Cadillac version that's going to be less painful, less risky, get you where you want to go much more quickly, but it's not covered. And we don't even, we're not even aware of it as Canadians because we don't get those options offered to us, or they're not talked about in the media very much.
I think that's a good point, because I think a lot of people intuitively think, okay, if I need to get my hip done or heart procedure, whatever, I'm going to go into Canada's first world healthcare system and they're going to give me first world technology. But as you've just explained, that's not always the case. Um, I want to ask you about your book and recommendations that you think the system needs to implement so that we can improve things. But before we get to that point, because we're talking about rationing of procedures and rationing of services, and that, wait times are a problem in this country. Um, Dr. Brian Day has tweeted out that he believes that there's literally thousands of people that are dying on waiting lists in Canada. What's your experience? How accurate do you think that is, that because we do have this rationing, that it's ultimately costing people's lives?
Yeah. So first of all, it's a tricky question to get at. I worked as a coroner for 5 years, and you have to fill out death certificates, and you never say death by waiting, right? It's always death from the heart attack that you think happened, or the cancer, or whatnot. So it can be very difficult to pin down, was this death from waiting or not? Having said that, people have done some good research trying to parse out that problem. A specific example of one study came out of the East Coast, I believe, out of Halifax just last year, where they found that there were 39 deaths. 39 patients died while waiting to see their gastroenterologist, GI specialist, or gut doctor.
Mhm.
And the average waiting time was 348 days. And many of those deaths were directly attributable to the problem for which they had been referred in the first place. So that's a very concrete example. Now, the Fraser Institute in 2014 tried to look at this more broadly and look at a very broad swath of the literature and come up with some predictions on how many people are actually dying. And they looked at the literature from 1996 to 2009, so a 15-year period approximately. And they found that all-cause mortality, which is just a fancy way of saying all the things that kill you,
Mhm.
so all-cause mortality was most statistically significant for women who were waiting. And so when they focused in on female patients who died as a result of waiting, or where waiting played a major factor, their estimate was anywhere from 25,000 up to the low 60,000s. I believe it was 62,000. And you can Google this or maybe put a link on your show.
Mhm.
The average number they came up sort of in between that was around 44,000 deaths that could have been prevented, or were at least directly attributable to wait times in that period from 1993 to 2009. Well, when you divide 15 into that, you get an astronomically high number, like many thousands of deaths
Mhm.
each year just for women due to waiting.
Yeah.
So I think it's a huge issue, but at the same time, it's kind of sad when we have to use death as our only reason to not wait. I mean, I've had health issues in my family. My wife has been sick. One day is a nightmare.
Mhm.
7 days waiting for a CAT scan of your head after surgery, after neurosurgery. I mean, that we're pretending to be completely ignorant to the emotional toll. Forget about the financial toll. That's huge as well. But is this what we would want for our friends and family? And absolutely not.
Well, what about, and I appreciate what you're sharing there with the big picture analysis, the stats and that. I mean, some people just say, oh, that's just the Fraser Institute, or that's just so-and-so's research, or whatever. What about in your own experience as a doctor? Have there been cases where one or more of your patients have passed away and you heard that and then thought, I bet you if John Doe, my patient, hadn't have had to wait whatever amount of time, if he could have got in more timely, that he would have lived, or she would have lived, or whatever. Have you had that feeling as a doctor?
Well, yeah, many examples. And instead of thinking of the examples of my own patients, because maybe my patients are going to end up watching this and I don't want them to say, oh, yeah, I think he's talking about me. So just to be clear, I'm not talking about my own patients.
Fair enough.
But a close friend of mine who this is sort of ongoing, and maybe he'll watch this and I'll get in trouble for him too. I don't know. But uh, his mom actually was diagnosed with a problem. This was, I think, 10 or 15 years ago now, and she needed a CAT scan, and there was a wait time of several months. And so he and his family and his mom at the time said, we're not doing this. Let's just go to Buffalo, get the scan. Like, that's the rate limiting step. Get
Yep.
the scan, bring it back to Toronto, show it to the specialist. And it turned out she had a tumor on the scan. And from that, they could arrange biopsies and treatment. And she got treated much earlier than she would have had she have waited, the 4 or 6 months to get the scan. And the specialist at the time said, no, this made a difference for your mom. It was a difference between survival or not. And she's been disease free since that time.
Mhm.
His father now, same person, went through a very similar situation, but they didn't go to Buffalo. He had some pain, and so didn't really have the same sense of urgency. But a CT was ordered. He actually ended up in the emergency department because the pain was so bad, and that finally bumped up the CAT scan. But by the time they got that, there was cancer all over the place. And so it's always hard, well, if we would have got the CAT scan immediately, if we would have driven to Buffalo 3 months ago when he first started with the pain, would we have been that much further ahead towards treatment or radiation? And would a treatable condition have existed at that point? We beat ourselves up with these kind of questions. But the
Mhm.
point I'm trying to make is that these issues are happening every day. People are continually asking themselves, well, you know, even in my own family and my mother, I just thought of this now. I mean, she went through a process. She's still going through the process of the cancer on her leg,
Yeah.
and delay in getting the biopsy read, delay in a repeat biopsy, delay, it's just a fairly straightforward thing. Cutting off a squamous cell cancer turned into, it's almost a 2-year ordeal with some massive radiation. I mean, who gets radiated for squamous cell cancers anymore? I mean, you just usually cut them off and you're done.
Wow.
So there are many stories that we could share, and I'm sure other docs that you would talk to would be able to tell you, yeah, I remember this patient and that patient, or even their own family members. And this is someone who's inside the industry who should be able to advocate for their family members. Now, my
Yeah.
mom's and dad are in Thunder Bay, so I wasn't on the ground there, but
Yeah.
but these are real issues, and it's not something that we can be proud of.
No, for sure. And I certainly hope your mom comes through everything okay. Same with your friend's father. Um, if we shift gears a bit now, what do we need to do? How do we, if you're the all-powerful minister of health and you have the power to fix everything, what would be a few examples that you think we need to tackle to address the problems in our system?
So great question, and you said we have 2.5 hours for this program, right?
Yeah, for 2 days, 2 days. Don't run a lunch.
That's right. I mean, there are so many ways that we can tackle this, and one of the problems is in assuming that there is one solution, or even there are half a dozen solutions, and we're just going to do this and we're going to apply it at the provincial level or apply it across Canada. I think the best solutions actually come from letting people closest to the problems design creative solutions as they go through. But just pulling out some ideas from other jurisdictions in the northwest in the states. I can't remember if it's Oregon or Washington. They have a list of everything that's covered, and then they just draw a line. Number 500 is covered. 501 procedure on your list of 2,000 procedures is no longer covered. So having limits on what's covered and what's not covered, that's a hard discussion to have, but perhaps we should have it at some point instead of this rationing by stealth. I think giving patients more power to decide over what's happening. As soon as you say that, people say, oh my gosh, he's talking about money and patients paying with their own money. Not necessarily. I mean, even if we gave patients power with vouchers or tokens or some other way where they could make decisions, if, if you have 1,000 tokens to spend this year, okay, this is going to put me to the front of the line tomorrow. There are opportunities for efficiencies in the way things are run. A lot of my time has been spent in leadership, so working with organizational behavior. How can we align people's incentives to get the emergency department, for example, empty more quickly? You look at how people function in the middle of the night versus in the middle of the day. The whole team behaves differently at midnight because they all want to have a nap, right? They want to settle down and clear the department and get people home, at least when we used to be able to get the department clear. So there's a wide range of behaviors that could change sort of on the front lines. And we could talk about funding. Why is it that we spend 99%? So the government covers 99% of all the care that doctors provide, and 99% of everything that happens in hospitals. It's a little less now because hospitals have to actually raise money with gift shops and high price parking, but that's a separate issue. It's still in the 90s,
Yeah.
a 90 percentage that government pays for, but yet government pays for nothing else. No, or relatively little of walkers and home care. Well, we pay for some home care, but supplies that you need for wounds and medications and dental care and eye care. In the 1960s, the cutting edge of what we could offer happened in hospitals, and it was provided by doctors and nurses. Well, the cutting edge of medical care, healthcare in general today is not doctors and hospitals. I mean, tons of it happens outside of the system. So just re-examining that dogma, or we talk about fixed false beliefs in medicine, which are delusions, right? The delusion that 99% of everything that doctors do must be paid for by government doesn't seem to make sense to me. Like, why are we as taxpayers paying for the care of a professional sports star, or someone who just won $2 million in the lottery? Or many people in our society don't need to have their care paid for by tax dollars, but we're just paranoid of even talking about that topic. And I think we need to have those courageous discussions and not think that the sky is going to fall. I mean, people, if we start off by saying people need care and they need more care, not less care, Canadians need more care than what we're currently providing, and have that as our benchmark. Hopefully we can actually get people talking in a more open way about some of these tough questions.
And we are, to my knowledge, basically the only country on the planet that says to people, you can't spend your own money to improve your own healthcare.
Yeah.
You give the example of a patient driving to Buffalo for a scan, CT scan, I believe you said, and that's because Ontario doesn't allow someone to reach into their own pocket and pay at a private clinic for a CT scan. Is that correct?
Well, yes, for everybody, unless you are an executive at a large company and your company can pay the facility fee, so
Yes.
that you can go to the Cleveland Clinic and get to the front of the line. Or if you're an athlete and you blow your knee out in the hockey game, you'll get an MRI that afternoon. Or if you're injured your right knee at work, actually I have a patient right now injured their shoulder at work. She'll get her MRI very, very quickly through the private, it's not really private funding, a special stream, we'll call it that. So advanced access for injured workers. But if she injures her left shoulder playing badminton or something, she'll be in the public queue. So there's all these opportunities for unequal access. And I've gone down a rabbit trail, not really answered your question. I'm sorry, you'll have to.
No, that's fair. I think that's the problem, right? Is that there are some times where people have these special exemptions where they can get access to care. But I think oftentimes, you mentioned an example, someone playing badminton and they hurt their elbow and they need a whatever, a ultrasound or MRI, whatever. They can't they have two choices in Ontario. They can either wait for the government to provide it, which could be many, many, many months, or
Yep.
they have to get in their car and drive to Buffalo or Quebec because it's allowed in Quebec. And this is the patchwork of Canadian healthcare, is that sometimes
Yep.
there are these options for private healthcare in certain provinces under certain conditions, but then
Right.
other times there isn't. So, I mean, an MRI is a good example. We just did a report and we found that there's now a majority of
Right.
provinces where you can pay for private MRI if you need one. Or you can use
Right.
the public system, but there are certainly procedures where you can't get that done. I believe, correct me if I'm wrong, but in Ontario, if I need a hip procedure, hip operation, I either wait for the public system or leave the province for faster care
Correct.
or more choice or whatever. Is that,
Yeah.
yeah.
There was one hospital that world famous. You've heard of the Schuldeis Clinic, and it was a private hospital that was allowed. It was grandfathered in as allowing private care in Ontario. And part of the reason was because it had such a fabulous reputation that it was allowed to continue offering its services. And I apologize too for drifting off the topic. You asked about whether or not it's right that people can actually purchase care on their own like they would for anything else in their life. I think the risk if of going down that path, though, really focusing on, it's my right to do what I want with my money. I mean,
Mhm.
that resonates with you and me,
Yeah.
and it resonates with many voters. But to have that as our only reason to develop a policy
Mhm.
can come across as heartless, and indeed it could be heartless if it was implemented in a way that really ignored the needs of patients. So I think there's such a robust and tremendous opportunity to really focus the discussion on meeting needs better than we're doing now, getting care to the patients who can't get care, dealing with the fact that poor people can't access care the way a wealthy person can in our publicly funded system. Like, forget about spending money, your own money. Just focus on the care that people are getting right now inside Canadian Medicare. And we've had literature from the 1990s onwards showing that, wealthier people get more care. I'm reading an article from the New England Journal of Medicine that's going back to 1999. A huge study, and New England Journal is premier journal worldwide.
Mhm.
People living in the highest quintile neighborhoods got 23% more cardiac procedures, heart procedures after heart attack, and they waited 45% less for them. And just last week in the Canadian Medical Association Journal, there was a large article about talking about the social determinants of health and how people who have less income, less education, live in a poorer neighborhood are not accessing care in the way that you or I could. Now, the spin of the CMAJ article was to say, well, therefore we need to redistribute more. We need to tax Colin more and tax Shawn more so that everybody else has way more money to spend. But if we leave that argument aside for the moment and just the simple fact that they acknowledge that we are not giving care regardless of ability to pay.
Mhm.
People who are articulate, who are educated, who are connected, who are wealthy, who live in nice neighborhoods are getting more and better care with shorter wait times than people in other neighborhoods who aren't connected or don't have the same level of education. Well, that's terrible. That's failing on the first promise of Medicare.
Mhm.
And so we need to have these kind of conversations and say, we don't even need to talk about, freedom and liberty. We just talk about, are we doing a good job for
Mhm.
our most vulnerable citizens? And I think we could do a lot better.
And I want to come back to that point you made about the connected and their access to care in a minute. But just on the medical tourism aspect, it was something that we've spent some time researching, is trying to get
Mhm.
data on how many Canadians are going abroad. The Fraser Institute had some estimates that they tried to put together. We actually got some figures from Statistics Canada, and we were able to calculate using their data that Canadians made at least 217,000 trips in 2017, specifically outside the country for
Yeah.
healthcare. And on top of that, you would have snowbirds where maybe they're down in the US for 4 months or whatever it is, and then they get a hip done while they're down there. So they wouldn't even be included in the total. But we've
Yeah.
got all these people that are going abroad for healthcare. It strikes me that as a nation, we're missing that economic opportunity. If those dollars had have stayed in Canada, then we could pay for, they could help create jobs, support companies that would pay taxes, that would actually support the public system and more. But there's the economic angle. But when people do that, there's a cost involved, and there are middle income people that are doing it too. It's not just the wealthy.
Yeah.
But if
Well,
we,
well,
sorry, go ahead.
no, I'm cutting you off.
Okay, I was just going to add that if we did have it locally in Canada, like the rest of the world does, that you would reduce the costs in a way for those activities, because people don't have to pay for their transportation to another country, their lodging, their food abroad, all those expenses, and you would make it, I think, a little bit more accessible for some people to come off the public system, use the private system, and help with the sustainability of our model. Are you, in your experience, without mentioning any patient names or particular details, is it common for you to hear from your patients that they've gone abroad for care?
Well, common is a pretty broad term, so it's not uncommon. I'll put it that way.
Yeah.
Certainly, it depends on where your practice is located. I happen to be in a rural community with I don't have a ton of people that tend to do that sort of traveling, but the ones who do are certainly make use of it. Um, it 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 it's odd that there was such a loud outcry over medical tourism, like you were talking about people coming, either leaving Canada to get care elsewhere, but also the reverse, right? Could we have people coming here to be getting procedures in empty operating rooms that wouldn't have been used otherwise? Well, there's an outrage, an outcry, right? The activists, the unions, they said, no, absolutely not. This undermines our whole system. We can't have people paying for care on our own soil, even if they aren't Canadian citizens. So they're very ideologically pure there. However, birth tourism is a huge thing in Canada right
Mm-hmm.
now, right down the road from my place at the hospital just down the road. There are a number of docs who advertise online to particular communities, and yeah, come here. You have to pay a lot for it, but you'll deliver your baby in Canada. Your baby is now Canadian, and you've paid me a ton of money. I'm making a nice part-time job. Actually, it's probably pays more than their work that they do in the Canadian system to provide this medical tourism. And yet we don't see marches on the streets and major outcry over that. People don't like it, the ones who know about it.
Yeah.
But so there's all this duplicity, right? On the one hand, to your point, your great research showing that there's not just tens of thousands like we used to think, but very possibly over 200,000 people who are going out every year for care
Mm-hmm.
on that direction. But then there's also people coming in for having their babies in Canada and paying for that. We even have, it was a Senator Paul Rand, or Rand Paul, I always get them mixed up, but he came to get his hernia done at Shouldice. So that's sort of reverse tourism. Obviously, he didn't go to one of our public hospitals. But why don't we have this discussion? It seems like it would be a rational opportunity to have. Again, though, like we said earlier, if we're talking about reason and finances and freedom, that doesn't resonate with the public. I think we're on more solid footing if we're talking about the care for our most vulnerable right now, right? If your mom was sick and needed care, what kind of care would you want her to get in our current system? So I think there's such a robust opportunity to just talk about that, and then using the tourism or the reverse tourism or tourism here to help improve the care we're providing for our most vulnerable. I think there's a great policy platform to be had right there.
No, for sure. I think there's a lot of benefits, whether it's freedom or it's the
Yep.
economic aspect. I mean, obviously, helping patients get out of pain. You know,
Yeah.
it's incredible when you talk to people about some of the pain and suffering that they go through.
Yeah.
But I think there's all kinds of reasons to be doing essentially what the rest of the world is doing, because when you look at our peers, they're often ranked higher than Canada's system, and I don't think that really helps us. I just want to ask you about that comment you made about doctors advertising to get people from abroad to come to Canada to have their babies is part of the hook so that they get the Canadian citizenship. Is that?
Yes, yeah, and to be clear, technically we're not supposed to. The regulatory college says we're not allowed to advertise for our services.
Yeah.
However, I don't think that extends to other countries. Now, if you wanted to have a whole talk just on birth tourism, I didn't prepare for that, so
No,
I
no,
shouldn't have brought it up. So, but there are other people that are experts on it. But
yeah,
yeah, no, absolutely. The main objective is, yeah, you have a baby here. Not only is it you're having a baby in a nice environment and paying for that extra attention from a well-trained physician, but the bonus and the big bonus is that your child becomes a Canadian citizen.
yeah. Well, that's fascinating. You've piqued my interest because I've certainly heard about it happening. There's been some stories in the news. I didn't realize it was as overt that there are
Yeah.
doctors advertising. So maybe
Well,
we'll have
there's a
you on again.
CBC article.
Yeah.
Yeah, a CBC article just from last month. Yeah, check it out.
I'll have to take a look for that one. So to come back to that point that you raised earlier about the people in the system having connections and being able to navigate it a bit more, would you be able to expand on that? Is that something that you've heard about, like that happens a lot? I mean, the Post Millennial, actually, that news site, they had a good story recently where they interviewed some doctors. I believe they were in Ontario, and they said, yeah, it happens. You
Yeah.
get the connected, pick up the phone, they try to get procedures done. What's your take on that?
No, it's a huge issue. I mean, the old joke is you go into medicine so you can get good care for yourself and your family. And it's a reality that happens and people haven't wanted to admit it. The post-millennial article is probably the most up-to-date example of that going on in Canada.
Mhm.
Perhaps you can put the link in your show notes. But even going back to, and I was telling you about this earlier, this is Arnie Aberman, right? At the time, Dean of the University of Toronto's Medical School. In the 1990s, and this is from a book edited by David Gratzer called Better Medicine. And he said, quote, this is Aberman saying this, quote, 3 or 4 times a week, sometimes I would arrange preferred access to medical care. I wasn't proud of it, to tell you the truth, because by helping someone I knew, I was hurting someone I didn't know. It's a zero-sum game, end quote. And so here's the dean of University of Toronto's Medical School being honest enough to admit it. I mean, kudos to him for saying that. Now, after that, as you know, that in Ontario, the McGuinty government passed the Future of Medicare Act, where it was essentially done to outlaw jumping the queue, and anyone found guilty of queue jumping would be fined $25,000. As far as I know, no one's been fined, but it's the soft things that happen. So, for example, in Emerge again, keep using that. That's where I've spent years and years working.
Mhm.
We would have dignitaries show up, and I don't want to say too many details on the dignitaries because our community is small enough that if I give too many identifiers, people will know which
I don't want
family
that
I'm
all the
talking about.
details
Yeah,
now, but yeah,
yeah. No, I'll get in trouble, and they're enough of a national figure that you might be able to guess who they are too. So a big time person, right? And both individuals in this relationship were big time people, and I remember it was a packed out evening, like really busy Monday evening, and I grabbed the nurse, said, you got to see these people, they were in a room in a stretcher, and I was like, how, wait a second, like they've only been here 20 minutes, they're already in a room, both of them with a stretcher and a curtain, private, off by themselves. I said, our wait times right now are 4 or 5 hours, at the time, and just to see the doctor. And here I was seeing these people 20 minutes, and I said, what the heck's going on? And
yeah.
she said, oh no, it was creating a distraction. It was creating a distraction in the waiting room. And I'm sure it would, right? To have these people, just to see them on TV is a distraction for people, let alone having them in the emergency department. Uh, but those kind of things are happening all the time. right? When I was a director of the emergency department, I was chief and then a medical program director. I would get calls routinely. Dr. Whatley, Mrs. Smith, I'm just making up the name, Mrs. Smith's husband is in the emergency department. Can you make sure that he has been seen? And so my job was to call the charge nurse and say, has anyone seen Mr. Smith? Does he have a bed? How's it going? Or to call the doc on duty and say, hey, what do you think of Mr. Smith? Did you see him? Well, that's a level of preferential access that just doesn't exist for you and I. If you're a $1 million donor to the hospital, people are making calls for you, and we're making sure that you're not one of the people lined up in the hospital hallway for 34 hours waiting for a bed inside the hospital after you get admitted. So you can't track this kind of thing, but it's a reality, and it's not right, and it doesn't have to be this way. It happens because of our overall approach to rationing care.
Yeah. And I think it's almost human nature, isn't it? Throughout life, if you need something or someone needs something and you have a connection to that thing that you want, you will try to use your connections to get it, whether it's helping someone get a job or get access to a good or service that's in high demand, is it not? Like, I mean, it just seems like human
Absolutely.
nature that we find the same thing in healthcare, that people would try to leverage their connections to
Yeah. Just because you've eliminated the the not the element, the aspect, the physical element of exchange doesn't mean that there isn't an exchange. There's an emotional exchange. There's a favors being exchanged. There's an exchange of authority, or you're a famous person in the community. I want to win your favor. I'm the doc. I really hope you like me and you remember who I am. There's all of these things going on. And so I'm sure some of my fellow physicians would listen to me saying this and say, oh, that is disgusting. That is so unprofessional of you. It happens. It
yeah.
happens. If I'm being approached by a patient who is, or even just a nice patient, someone who is nice and kind and polite, I'm already more predisposed to try to be nice and kind and polite to them and not make them wait. And or the reverse. Sometimes people who are nice and polite, you say, oh, they're so nice, I know they can wait. But this other guy, he's a real grump, so he needs to get in fast. So I don't want to say just being nice gets you in fast. Sometimes people learn that. In fact, this reminds me of a story. One of the family docs in our community wrote me a letter, because he had sent his patient back to the emerge a second visit. He said, I told him to go there and raise hell. He said, you go there and you raise hell. Don't go home until you get the care you deserve or you need, or what he thought the patient should have. So there's all of these relationships going on back and forth, and get this person to the head of the line or get that person to the head of the line, and oftentimes they're legitimate, right? I'm worried about this patient. They have chest pain. They need to be seen right now. Oftentimes that's not the issue. It's the fact that, hey, I know Colin and I see you in the waiting room. I say, Colin, hey, how you doing, man? What are you here for? Oh, my kid's got a fever. No way. Let me see your kid. Like those relationships are happening all the time. A nurse who works in the department walks over and says, Shawn, man, what do you think of this mark on my hand? And oh man, you should see dermatology. Here, give me a form. I'll make the referral right now. I had a red eye once, iritis, and the ophthalmologist was in the department. I said, hey, Eugene, can you look at my eye? So my wait time from complaint to being seen was about 30 seconds, right?
Yeah.
Well, it's that kind of access that's going on all the time, except for you, because you don't get it unless you know someone or you have to pay for it. Well, that's or in the States, right? That's not fair. And so the people with the power to make decisions and the power to really change this whole construct are the ones who have great access, or they know Arnie Aberman, like in the book that I just quoted, or they can fly to the States and to get a special procedure that's not available here. But only 4% of the Canadian public ever needs acute care in any given year. So you're talking about a tiny sliver of the voting population, and it's much nicer for the 96% of the rest of us to keep living on this dream that I'm going to get care regardless of ability to pay. It's going to be, world leading, high quality, free, that's the big point, care.
Yeah.
Well, is it really free, right? If you're having to wait months and sometimes years and taking time off work, and we know it's not free because workman's compensation bumps people to the front of the line and gets them their treatment and their tests and their consults within weeks or days often, as opposed to months. So anyways, I'm going on and on. You better cut me off.
No, that's a good point. I mean, if you're going to get hurt on the job, because you can get in faster through workers' comp. But your comments there about, just people with access, especially those in power who are making these decisions, having getting preferential treatment. Sometimes it reminds me of what Dr. Brian Day has set out in British Columbia. He, of course, has his private clinic, and the government's trying to shut him down in court. And he's said that, many of the people who are advocating against having that private option alongside the public system, they go through his clinic. They don't want to wait, so they go to a private clinic like his, and they're trying to get access. I'm being mindful of your time here too, so I don't want to push it too much, but I just want to ask you, there's so much more we could talk about. I'm going to try and twist your arm at some point to have another discussion, but do you have your closing thoughts about what we've talked about?
I think we need to put patients right at the center of our discussion. The challenge with this is that it's such a exciting, huge topic area that I'm not saying, I'm saying this to myself and to you and to all of us, that we can get really excited about the payment per capita or transfer payments or funding or comparing the number of beds, the number of the docs per 1,000 patients, and all these wonderful numbers between us and between provinces and between countries, and completely lose sight of the patients. So I think, and not just to say that, right? Everybody says that, oh, patient focus, patient this. I'm saying put their patient and their problem right at the very center and say, if that patient was my sister, my nephew, or whatever, what kind of care would I want for them? So starting with that. And then the second comment I would make, and I wouldn't say anything else, is that if we're making this topic sound so complicated that the regular interested person feels they can't be involved in the conversation, we're doing something wrong. And very often we're doing that because we don't want to hear from you. We want to make it sound complex and, well, let me tell you, the research actually shows this or that or whatever, because we don't actually like what you're having to tell us. We don't want to hear what you're having to say. We need to make this more of a broad discussion and let regular people just talk about it. And you're, regular voters, interested people who are wanting to read on this topic, we should listen to their opinions. We're not sending rockets to the moon. We're not doing heart surgery when we're talking about access to heart surgery. Your opportunity to access, or the kind of experience that you have or enjoy as a patient, that in itself is not heart surgery, right? That's stuff that everybody can talk about. The number of dollars that are involved in that, we can all talk about that. And so we have to stop thinking this is so complex and so tricky or scary that the regular average interested person on the street can't talk about it. And so that's the second big hobby horse I have. Number one, patients, experience, how well we're treating them. Are we treating them like family? And number two, are we shutting people down? Are we telling them they're there, patting them on the head? I know that's what you think, but let me tell you, I'm the expert. No, that's not right. I mean, anyways, I better stop getting excited.
No. I agree, and I think it's especially important to talk about the stories behind the numbers, because I think you're right. Too often healthcare discourse in this country, it takes place up here, big numbers, 50,000 or 80,000 or whatever the figure is, people on a waiting list in BC. Well, there's real stories behind those, and that's what we're trying to do a lot, is bring those stories to light so that people understand better. Hey, wait a second, it's not that there's 80,000 on a waiting list. There's a story like Jenny McKenzie, who's waiting in severe pain, and she can't walk across the room now without thinking about it and planning it out because it's such an
Mhm.
ordeal, whereas she used to be active. We need to understand
Yeah.
those experiences that people are going on. So I think you're right. We do need to really keep patients at the front of
Yeah.
at the middle of the discussion, and that needs to be the focus. I just want to ask you one final question. Your book, again, No More Lethal Weights. If anyone wants to buy a couple dozen copies, where
Oh, at least.
please, for all their friends and family,
Yeah, you and my mom will have bought a dozen copies.
whereabouts can they buy your book, Doctor?
So Amazon.com is or .ca, sorry, .ca. It's on .com as well and .uk and all the rest, but yeah, probably Amazon is the best place to go. It's available on Indigo as well. Yeah, a surprising thing, non-medical people often understand the concepts in that book more easily than people within medicine, because those of us who've lived and done this for the last 30 years were saying, well, wait a second, you're getting rid of stretchers? What are you doing? No, you can't do that, right? And so we're so baked in the ideas of, no, this is how you do it in healthcare. This is how you do it in an emergency department. When we read the ideas that we've put into that book, I say we, because it's really a team of us who've populated the ideas that go in there. I just happen to write it and sort of conceptualize the things. um, People who have a fresh mind walk in and say, yeah, no, that makes a lot of sense. Why isn't everybody doing this? And so I would encourage, yeah, the average reader, with no experience in emergency medicine, to pick it up, and I think they'll say, yeah, I think this makes sense.
Oh, good. Well, I'm glad that it's so user friendly, because I think that we do need a lot more people talking about the system. I think it's important. Um, for patients, right? I mean, at the end of the day, we have a system that could use a lot of improvement. As you pointed out, there's some things we're doing very well, but we should always be, I think, striving to improve things. And patients need to be a big part of that discussion, because at the end of the day, if we're going to see changes, we're probably going to need some votes behind different people that want to make those changes. And so people need to understand what we can do to
Yeah.
improve things. So I'm glad to hear that it's very user friendly for patients to pick up.
Yeah. Yeah, I
And
think so. I think it is. That's
perfect.
what my mom said.
There we go. Thanks a lot for your time today, Doctor. I really appreciate
Thanks, Colin. Have a great day.
you too.